I am the Apollo Hospital, Navi Mumbai. So in 2 or 3 minutes, sir, will be starting, and just in 2-3 minutes, sir, will be starting.
Hello, sir. Good evening. Manoj sir, good evening.
Yeah, hello, Akhilesh.
Hello, hi, Dr. Sharmili. Good evening.
Good evening, good evening. We're all waiting for you.
Yeah. So Dr. Manoj is already joined, and Dr. Gunadri is also there. I'm waiting for Dr. Iyer and Dr. Govil to join.
Yes,
And then I think within 1 or 2 minutes, I think we'll be able to start.
sure,
The
no worries.
yeah. Sure.
Hello, Milind.
Hey, Manoj, how are you? What time is there?
Oh, 10:30.
Yeah.
Bedtime.
Yeah.
I can share my screen meantime.
Yes, sir.
Can you guys see my screen?
Yes.
Yes.
The meeting.
Yeah. Good afternoon, everybody. Akhilesh, can we start?
Yeah.
Just wait for a minute.
Okay. If you're happy, Alkesh, I'll start.
Yes, sir. Sir, just a small bit of introduction, sir, before we start.
Yeah,
So,
sure.
So I welcome you all to this academic sessions on CRRT. So I am Dr. Gunadhar. I am consultant intensivist Apollo Navi Mumbai. And with me, my colleague Dr. Akhilesh, he is also working as a consultant intensivist Apollo Hospital Navi Mumbai. So the whole purpose of this program is to disseminate the knowledge among our DNB trainees and fellows, and to have a first-hand knowledge about the other higher modalities or any advances in critical care which is going across the world. So that is the reason, sir, we are here, sir. And again, I welcome you all on the behalf of Apollo Hospital and my department. So just a small introduction. I'll just hand over to Akhilesh, and Akhilesh can introduce, and then we'll be starting the session, sir. Thank you.
Yeah, thank you, Dr. Gunadhar. It's indeed a pleasure, great pleasure and privilege to have the stalwarts of critical care and those who have done tremendous work in the field of renal replacement therapy. We have Dr. Manoj Singh, who is the consultant critical care specialty at Canberra Hospital. And I welcome you, sir, wholeheartedly, and I hope the students will be benefited a lot. I still remember you. I mean, you have been director for the workshops of critical CRRT. We have conducted one CRRT workshop along with you. It was immensely useful to the students, and they would like to have it more often and now. So with this, I would like to welcome the other panelists also. We have Dr. Shiva Iyer. Shiva Iyer, sir, is the head of the Department of Critical Care uh, at Bharati Vidyapit. He will be joining us shortly. He said he's a little busy, but he'll be shortly joining. And then we have Dr. Deepak Gobil, who is chairman of Critical Care Services at Medanta, the Medicity, and the president of ISCCM. I am really privileged to have you, sir, along with this esteemed faculty group. And we have the panelist, Dr. Sharmili Sinha. She is the head of the Department of Intensive Care at Apollo Hospital, Bhubaneswar. Welcome, madam. I welcome you. And we have our own intensivist, Dr. Swapnil, with us. Swapnil Khadke is the critical care specialist at Apollo Hospital, Navi Mumbai, and he has been immensely, passionate about doing CRRT's bedside. He is a bedside clinician. With this overview, I would like to hand over this session to Dr. Manoj Singh. And at the end of the session, we will have panel discussion. Over to you, sir.
Let's just, I'll introduce Dr. Milind. Dr. Milind is one of the leading intensivists in Australia. He is basically working as a critical care specialist and consultant in one of the institutes, Lil McQueen Hospital, Adelaide. And he has a lot of publication and presentation, and he's also very passionate about the teaching. So I welcome him to this group, to this academic group. And then I hand over the session to Dr. Manoj and to present the talk. Thank you, sir.
Yeah, so good evening, everyone. And thanks, Akhilesh, for providing me the opportunity to talk. And it's always good to get in touch with you. And because it's a long talk, I'll start off with the slides. So I come from Canberra. So I am basically did my training, my DNB training or FNB training from Hinduja. I was in Hinduja for 4 years. So I'm in Canberra for the last 15 years or so. That's the Canberra Hospital. It's a beautiful place. If you come to Australia, come and visit me. I would love to host you all. So we'll start off with the case. So when Milind called me, sorry, not Milind. So when Akhilesh called me, he asked me a lot of questions to cover or a lot of topics to cover. And I thought it will be a very long talk. So I've tried to actually summarize a little bit of everything in this talk. And maybe in future, we can actually subdivide the topics and specifically go in detail in one of each topic. So I like to start off any talks with a clinical scenario so that we can actually correlate what we are planning to do or what we are planning to prescribe at the bedside. So I'll start off with case one. Imagine there's a 49-year-old male who is 70 kilos, has been admitted to your unit with streptococcal toxic syndrome. He's got AKI, he's got respiratory failure, he's got septic shock, so he's got multi-organ failure. His creatine is about 1.6 milligrams per DL. I talked more about micromoles, potassium 4.5, bicarbs 19, and a lactate of 1.9. His urine output for the last 4 hours is about 10 to 15 mils an hour. His pH is 7.25. So would you start this patient on CRRT or not? So I'd like to ask questions, so feel free to answer. So will you start this patient on CRRT? Or would you like to start him on any replacement therapy?
Yeah, if he's on triples, I think what is the vasopressor requirement? I would like to know. And what about his hemodynamic stability? So
he's on 15 of NORAD. 15 mics and minutes of NORAD. Sorry. So he's on 15 of NORAD.
Okay, so
Go ahead.
in view of the hemodynamic instability and metabolic acidosis, it is better to start with CRRT early for this
Yep.
patient.
Anybody else has any other comment?
Yeah, acidosis is an organ support which is mounting. So it would be
Yeah.
make sense that in the coming time soon is not going to make it turn around. So in view of the volume management and all other things, keeping in mind for all metabolic optimizations, I would start considering CRT definitely.
Sure. So there are two answers which says yes. Anybody else has any difference on opinion, want to wait, or just want to start?
I mean, there are studies which have shown that early versus late CRRT has not really shown significant benefits, and I would like to probably wait close observation.
Yep.
Would be my key way forward to manage this patient, and probably I will start CRRT if there is worsening of clinical condition here onwards.
Yeah. Again, yeah. So start CRRT now, or should we wait for absolute indications for renal replacement therapy, like what we read in a textbook or medicine textbook? When do we start patients on dialysis? So the urgent indications are, of course, we know of hyperkalemia, severe metabolic acidosis. This patient doesn't have any severe metabolic acid. He's not fluid overloaded. He is in uremic, doesn't have any of the uremic pericarditis. So again, there is a concept called renal replacement when you have almost no urine output. The patient doesn't is severely acidotic, so we are replacing the renal function. Or there is something called as renal support therapy, where we start the renal replacement therapy a bit early, even though there are no classical indications. And this is like somebody said, oh, the fluid status, it will help me with the fluid status, it will help me in managing the fluids. Most of these patients, or many of these patients, still require ongoing fluid resuscitation. I'll definitely go through the history, see how much fluid resuscitation this patient has. Is this patient's volume status right before I think about CRRT? So there are a lot of things at the bedside I'll try to optimize and see before I think about starting CRRT now, or wait for. So what does the evidence say? So yes, a place has already said that the evidence doesn't support. So if you go back about 10 years or so, there was some lot of meta-analysis which came, which showed that early replacement, early start or early initiation of CRRT or renal replacement therapy favored overall outcome, but more and more recent meta-analysis and studies have actually gone away, and they've said it doesn't actually show any benefit in starting the renal replacement therapy. And it's also important to know is what defines early and what defines late CRRT. So does anybody know what definitions have they been used in the various studies or meta-analysis? What defines early renal replacement therapy, or what defines late replacement therapy?
So institution of CRRT would be based on KDIGO staging, basically, stage 2.
Yeah, so what defines, when I say I want to start early, does it mean as soon as the patient comes to my unit and has those numbers, do I start CRRT? So what is my definition of early CRRT, and what is my definition of late CRRT is something that I want to know.
Yeah, I'm not quite aware of those, definite definitions of these concepts, but in my practice of years, I would imagine that somebody waiting till the definite indications, as you showed the first one of the previous slides, absolutely. If you wait till you reach as those points, absolute indications, that would be something constituted as a late initiation, versus those less urgent or definite indications, or you can, always stamp it as an early initiations. But more or less, it is always, it's a clinician's discretion, always customized to the patient's metabolic status. That always happen.
Yeah, I agree with your answer. So We
I
often
also
look at,
totally agree with her. Basically, whenever there is relative contraindication and
Yeah.
absolute contraindication, so whenever we reach to the absolute contraindication, we don't have to wait. No, absolute indication, we don't have to wait. But whenever there is a relative indication, and if on clinical basis, if we can wait for some time, maybe by closely observing all these dynamic parameters, or maybe the what is going on in the bedside, then it will be early and late. Definitely can
so
be
yes,
defined.
you'll be surprised what does early and what early and late is defined in literature. So somebody from they have defined from the time of sepsis to the inception of CRT less than 24 hours. We don't use that definition for early CRT at the bedside. So I won't follow any of these kind of studies who have actually done a study based on this definition. So early of at the time when you have a patient sepsis, and within first 24 hours, if the patient still has it, I will start him on CRRT. If it's persistently shocked, I don't use that definition. I don't use either the definition of GFR of drop of more than 25% at the baseline. I don't use that definition as an early definition for my patients as well. And the interval between the early goal directed therapy and the CRT of about 24 hours or 26 hours, again, I don't follow that as a ballpark in my bedside for my patients. From the time of start of vasopressors to the initiation of CRRT at 24 hours, I don't use that definition for early CRRT as well. And then renal replacement therapy started within 12 hours of onset of kidney injury. And kidney injuries can be mild if you use the rifle criteria. A small rise in the creatinine doesn't mean that I will start within 12 hours of rise in creatinine as early CRRT. So again, it's a vague definitions that people have used in various studies, and then we quote these kind of studies or quote this kind of meta-analysis saying I'm an early CRRT person, I'm a late CRRT person. When I don't agree with this kind of definition, I don't use these kind of definitions at my bedsides. Now there is a recently more published studies, and again they kind of use the same kind of definitions, early versus late. Or if the urine output is less than 30, I will define it as early. If the urine output is less than 20, I will define that as a late. Again, I'm not sure these patients are fully resuscitated, not fully resuscitated. What is the volume status? And so again, SAP score, I don't use SAP score to actually define my early and late definitions as well. Creatinine clearance, oliguria, yes, maybe, but I look at the patient as a whole. I mean, it's not just one number that defines me an early versus late. So again, if you look at this kind of studies, I mean, you need to, whenever you look at an analysis, it's important to know what studies have been included in that, what definitions they are using to actually define. And that's why if you look at these kind of definitions, it's recently more and more, when you look at these meta-analysis, they are all negative. So there is no difference in the outcomes, whether you start or delay. It's in the end, you have to look at the patient saying, what is the trajectory? What is the likely trajectory? Is it getting high and low? So early versus late, have we reached any consensus? So all-cause mortality doesn't actually make any difference to the mortality if I start the CRRT early or if I start the CRRT late. This meta-analysis showed that the dependence on dialysis on day 90 was there if you start them early. Length of the stay, yes, it may decrease in your group of patients, but again, it depends upon what subgroup of patients are you actually starting these on. So again, if you look at few of these studies, the few of them were cardiac patients, few of them were septic patients. Obviously, when you have septic patients versus cardiac patients, the outcomes are and length of stays are a little bit different. And the recovery of renal function, again, doesn't change the outcome even if you start early versus late. So there is no difference in outcome. And yes, you have, if you start early, you have more electrolyte disturbance, you have more hypotension in the earlier group. So answer is I would wait, and there are pros and cons to each thing that I use. There are times where I use early, where I feel, oh, these patients come with, say, for example, a post-op patient comes in after a significant bowel perforation, had a significant bowel perforation, had four-quadrant peritonitis, they've done a surgery, and has quite significant bowel ileus. He's gone ARDS. He's quite severely septic shock. Feeding would be a bit of a difficult. I'm going to start him on DPN early. I want to, is an ongoing resuscitation going on, and I feel this patient is something that I will think about. Oh, I need to start TPN. I need to make sure there's enough room. I don't actually fluid overload him too much. And these are the occasions that I think about, yeah, I would early CRRT may help with my fluid balance and start a bit early. Are there any exceptions to the rule? Are there any patients where I would say definitely I want to start CRRT early, like one I described just now? But are there any other exceptions to the rule? Where, yeah, I would say this patient's definitely I start CRRT now.
So patient is already in anuria and patient is in volume overload, extremely.
Yeah, apart from
dynamically
kidney failure, TKI patients, any other patients.
and patient is in septic shock with high endotoxin levels. If I have high levels of
Any other
PCS
patient?
levels are very high, probably.
What about poisoning patients?
You can, yeah, poisoning patients, yes, I would. There are quite a few exceptions on the rule. If you want, there are certain poisons where you can remove the toxins or are dialyzable toxins. I would definitely start these kind of patients in
I would like to know from Dr. Govil also if there are any exceptions to his rule, his practice in Vedanta Medicity. Sir, can you highlight your views on this? Probably he's not there. Let us go on ahead. Actually.
Yep. So, yeah, anybody was trying?
Like certain conditions like severe malignant hyperthermia, anaphylactic shock. So those are the cases I think I would like to start CRRT early.
In anaphylaxis and so going back to this patient, so
one condition that we start CRRT a little early on despite having a kind of even without the renal indication is somebody with the acute liver failure.
Yeah,
especially with a very high ammonia and all these things. Probably starting that even without any kind of renal indication.
Yeah, fantastic. So fantastic. Any indication where there is no renal indication, hyperammonemia, acute liver failure is a fantastic answer. So.
And even patients with the cardiogenic shock will be an ideal candidate to start CRRT.
Yeah, I mean, if you're thinking about fluid removal, yes. But again, these are all exceptional. I'm talking about not the ones that we have discussed. I like the liver failure answer quite, and the overdose answers quite well, where there are no classical indications, but we want to dialyze that the toxins out. So yeah, so this patient's now got further worsened. His potassium's now 6.5. And what will you do next? So he's not started on CRRT yet, but his potassium 6.5. What do you do next? You've taken an ECG and it shows signs of hyperkalemia. What do you do next?
The immediate potassium correction measures.
Yeah, so we start off with medical management. We just don't jump on looking for a VAS cath. We need to make sure that we treat the patient medically. Often treating the patient medically buys us time because again, priming the circuit, loading the patient machine on, priming the circuit, placing a VAS cath, confirming the position, all takes a bit of time. And meantime, we need to make sure we don't forget the basics and continue the medical management. So next is vascular access. So what vascular access do you use? And what do you prefer? Which sites you prefer? Or what kind of catheters do you use in your unit? Or what type of catheters do you use?
Most commonly right internal jugular vein, sir.
So yeah, right jugular, internal
It is
jugular.
available and it is not thrombosed.
Yep. Any other answers?
Femoral access can also be utilized if the jugular.
Yep, femoral access can be also be utilized. What else do you think about when you think about the dialysis catheter? Are there anything that else that you use or think about apart from site?
So Generally, for femoral, we use long catheters,
Yeah, long
and for
catheter.
jugular, we use curved catheters.
You curve, so you look the, yeah, so the curve one, so they are more one of the permacats. Yeah, tunnel vas cats you're talking about.
But in acute indications, usually this tunnel
Yeah.
gets inserted. It is
Yeah, we don't use either the tunnel vascular. They are kind of patients who require
time.
ongoing CRRT, so are persistent failure.
And
So
depending on the
what
patient,
kind of catheters do you use? Do you have any kind of catheters? So one of the things that you can think about when you're using the catheter is whether you use a step kind of a catheter or you use side port catheters. So there are quite a few different types of catheters in the market, and the disadvantage of having side hole catheters are that if you are hypovolemic and you if you have a patient who's got hypovolemia and develop an acute renal failure and you try and dialyze them, so if it can actually the vessel wall can actually obstruct the side holes, and then you can have quite a significant negative pressure alarms. So yes, you need to make sure the length is right. It's in the big vein and preferably doesn't collapse. So that's why we often try other types of catheters as well. But in our unit, we use side port ones. But there are times where we go for, especially in the patients who are hypovolemic. So, for example, patients with pancreatitis where there's a lot of third spacing and they have and they are in renal failure, we do actually at times go with another types of catheters. The other thing then when you think about dialysis is what modality or what type of dialysis do I use? Do I use intermittent dialysis? Do I use continuous dialysis, or do I use a kind of an hybrid therapy in between? So again, each unit uses whatever they are familiar with, whatever the nurses or the teams are familiar with. In my unit, we use mostly or most of the time continuous CRRT or continuous renal replacement therapy in acute phase. So we use CRRT. Basically, we have a Prisma Flex and Prisma Max machines, and we don't do hybrid. We don't do SLED in our unit. And when patients recover and they are hemodynamically stable, we do intermittent. So I'm not sure how many is there anybody who uses hybrid?
yeah, we do it at times actually when if you have a high patient load, there are multiple simultaneous patients who require, because machines are only two, and sometimes under compulsions we do use this hybrid mode. But this is popular among the critical care teams. It is usually being favored by a nephrology team as a, but we are inclined towards CRRT whenever it is available. The machine is free.
Yep.
Well, I use a lot of hybrid modality nowadays compared to previous years. The CRRT, I call it as IRRT, intermittent renal replacement therapy, and which is extended. Some people call it extended dialysis or SCRRT, slow continuous low efficacy. And the reason I started using more and more because of some of the advantages we can get. CRRT goes for ongoing for 24 hours, maybe more. Anticoagulation coming with that, and the patient are stuck with that, and we can't do the investigation in the CT or something. So we have both technologies: the CRRT Prismaflex machine, also the Fresenius machine. So I started using much more. Previously, people used to get quite hemodynamically unstable with those, but nowadays with the new filters coming, they are tolerating much better with this low dose iron drops requirement. And I think, as Sharmili commented, it's we can utilize for more patients as well.
So it depends upon what you have. I'm not going to talk much about hybrid in this talk. I'm sticking more on continuous renal replacement therapy. You can actually prescribe or modify your prescription for continuous to match the SLED. So it depends upon what you need to know what you're prescribing, and you can do a fast, rapid renal replacement therapy with the Prismaflex machines as well. So yeah, so this is most of the things people have already talked about. Yes, with hybrid techniques, you can go up to about a bit higher on the blood flows, but again, you can go on the higher blood flows on the continuous renal replacement therapies as well. The intermittent are much higher. You can go up to 400 as well. And again, with hybrid, yes, you need a bit of an water supply and you need a bit of a drainage pipes. I'll just keep all that. I will stick to the dose. So yes, so we decided to start CRRT in this patient who's hyperkalemic. And what mode do I start? What dose do I start? What filter type I start? What do I look at first? Do I look at the patient? Yes, my patient's already, I know it's hyperkalemic, and that's the indication of my CRRT. What do I do? What do I look at next? What do I think next? Or do I look at what I want to achieve? So it depends upon what I want to achieve and how fast. So in this patient's getting more and more hypokalemic, and I want to correct the potassium as early as possible. So where do I start? What do I do?
Basically, when you start, we have to, for this patient on high dose vasopressors and worsening metabolic status, hyperkalemia mounting, you have given the medical measures. We'd like to start with continuous renal replacement therapy. Mode, I'd like to start with CVVHTF in this case. And as assessing, you have to assess the volume status, which is not quite implicated or understood from the case scenario though. So dose initially we'd keep it say standard between around 30 to 35 mLs per kg per hour. Filter type in 69, that's the common one that we use for CVVHTM for CRRT. That's the one we use here. And if it is hyperkalemia, the solution electrolyte concentrations have to be balanced accordingly. And I would rather keep it a dynamic prescription rather than leaving it as it is for the next 24 hours. So I would review it.
Yes. Any other answers? I like that answer.
Yeah, obviously the continuous veno-venous hemodiaph filtration will be a good option for him. And with the dose, as rightly told by Dr. Samili, it varies from the 30 to 35. I like to keep on the slightly higher dose because of multiple reasons. Because the more dose you give, the lesser. Sometimes the machine tends to deliver the lesser because of multiple factors. So in my opinion, 30 to 35 ml per kg will be a good dose. And the filter types depends on the situation where the patient is. Like normally we prefer it's a M100 filter, but sometimes if the patient is in septic shock or the patient is having cytokine storm, then sometimes in those cases there are specialized filters like auxiliaries or something like endotoxin filters are available. Somebody that sometimes we use. But routinely the normal dialysis filter we tend to prefer on the dialysis. And obviously every patient is different. So we have to look at the patient clinical condition and depend on that we keep the blood flow, the dilated flow and the replacement fluid.
Fantastic. So I also look at this when I think about what mode do I use. I want to know whether I need CVVHDF, I need more kind of larger molecules that needs to be taken off. So if that's the case, I will tend towards CVVH. If I'm just thinking about hyperkalemia, I can just dial in CVVH. So this is important because again, it helps me decrease the cost. But when I actually prime my circuit, yes, I start off with CVVHDF because again, if I want to then modify or decrease, go down on CVVH or do CVVHDs 24 hours later or 12 hours later, I can then modify. But if I start my circuit when I'm priming as a CVVH, I can't go up to CVVHDF. So when I start off with the CVVHDF kind of a priming mode so that I can modify and go in and modify my mode depending upon how the patient behaves later on. So in this patient, hyperkalemia is something that I need, and diffusion, which is nothing but CVVH or CVVHD, is what he needs. But if he had, so for example, quite significant pro-inflammatory response, as Gunadhar, you were talking about, then I may think about CVVHDF, or there is other molecule that I want to take out, like a myoglobulin. If somebody has a rhabdo, I may then tend towards going to CVVH. But overall, I start off with CVVHDF. Filter depends upon what filter you have in your unit. You don't have to specifically hunt for a filter. I only look at the surface area depending upon the patient's weight and what how bad hyperkalemic they are. So, if, for example, a patient has hyperkalemia to do an ischemic limb, rhabdo, I need a bigger surface so that I can actually clear things much faster. So, I think that way. And if this is a simple patient with simple hyperkalemia, I'm happy with the standard filter. But there are times where, if there, for example, there is an ischemic limb, there is a quite a high what do you call, potassium production and release, I may actually go for a higher a bigger size filter, because then I can actually also increase the blood flow rate, because bigger the filter, the more the higher the blood flow rate it can tolerate. And that's important as well, because again it then also impacts on my filter pressures as well, because if my blood flow rate's too high and my filter is too small, the filter pressures will go up, and there's more likely to have not only the fiber fractures but also high filter pressures as well, and then things starts getting a bit so as Gunadhar, you talked about Osiris as well. I don't use Osiris in my practice, even though patient has mild sepsis, septic shock patients, even they have around even when they are on high inotropes or on NORAD and vasopressin, I have a very high threshold of using Osiris. Maybe in the last year or two, I may have used it once or twice, where I make sure the ferritin levels are quite high. There is quite a significant amount of they are on the right therapy. Make sure all the other basics are right. Osiris I have not used much, but we do have in a unit as a standby if need be. So yeah, it all depends upon what I want to achieve, what ultrafiltrate do I want to use, what blood flow. So somebody said, okay, CVV HDF. So and you set the dose of 35. So that's the effluent dose. And what does that mean? In a CVV HDF, what does that effluent dose mean?
See, the effluent dose, if you're using the CVVHTF, usually for ease of calculation, let's take the patient. I think your patient also is 50 kgs. So if I'm using a dialysate of 1 liter, that is 1000 ml, and replacement fluid of 1000 ml. So total effluent becomes 2 liter. 1000 plus 1000 is become 2000 ml. And now that is going to be a reference dose. So this divided by the kg body weight of the patient. So 2000 divided by 50 kg comes to 40 ml per kg per hour. So that's how we decide a rough calculation. It of course varies from patient to patient according to the body.
It depends on patient to patient. Fantastic. And how do I decide the blood flow rate?
Usually it is set between, when you're in a CVV, CRRT mode, between 100 to 150 ml per hour. And depending on the dynamics and the rate of clearance you want to achieve, we can always manipulate it. But usually in our practice, we go up to 150 to start with always, not more than that when we are commencing.
Why, when you're thinking about, especially with CVV HDF, we do replacement therapy as well, as you said. We can give replacement either pre-filter, we can do replacement post-filter. There are advantages of pre-filter and post-filter as well. If you do pre-filter, yes, it helps diluting the blood, less likely the blood will clot. And but again, the efficacy of my dialysis actually goes down. When I do post-filter, again, there is a risk of blood clotting. Are there any specific things that I need to keep in mind about the blood flow rates when I'm doing CVV HDF?
Yeah, so the most important thing about the blood flow is it depends on the dialysate flow rate actually. So there has to be a minimum blood flow, like if you are doing a certain modality. So the basic modality, if you are doing a CVV SDF or CVV SDA, in those cases, ideally it should be more than 2.5 to 3 times the dialysate flow rate per minute. Otherwise, your machine will not going to work properly.
Yeah, so this is quite important because again, it all depends upon the ultrafiltration as well. So this is what it is, the dose that I was talking about. We need to understand when we do CVVH, this is the replacement fluid is the dose. When we're talking about CVVHD, the dialysate that I give is the total dose. When I'm talking about CVVHDF, this is the total dose of the dialysis. We've gone through that. Weight is quite important because again, and the hematocrit is also quite important. Why is the hematocrit important to know? So weight is important because we are calculating everything per kg body weight depending on the patient. Why is the hematocrit important?
Because that will determine the clotting and the stability of the filter. So if the hematocrit is more, in that case, I like to prefer to use the pre-filter replacement rather than the post-filter replacement.
Yeah, so hematocrit is important because we also calculate the filtration fraction. So filtration fractions. So this is the basic diagram which I'll skip through the CVVH. I'll directly go to, say, for example, where people have started the dose. So 30 to 35, I'm happy with that. If the patient is highly catabolic, as I was talking about, has a lot of potassium release, acidosis release, has gut ischemia there, I may even go higher than that in the initial phase till the patient stabilizes in for the first 6 hours and then come down. And it all depends upon how the patient is. So when we say we can go even, say for example, in this example I've said I'll start off with 40 into 70 is 2800 mils per kilo. And depending upon what mode I have, I can actually adjust that. So we say, for example, have started CVVHDF. I can use my dose as, let me go back there. I need 2800 as my total dose. So I can use all as 2800. If I use all 2800, it will be CVVHD. I can use, say for example, a liter of dialysate, 1800 of replacement, total will be 2800. That will be my CVVHDF. If I want, I can use 2000 as my dialysate and only 800 as my replacement. That would also give me a dose or total dose of 2800. The advantage of dialysate is it's basically looking at small molecules. I'm targeting more towards dialysis. So in a hyperkalemia situation, I want more of the hyperkalemia situation. I can actually dial 2800 and then continue with my relay replacement therapy and I'll achieve that clearance. The advantage of when you dial higher dialysate rate, you don't need much higher blood flow rate to go with it. But when you use diafiltration or hemofiltration, you need a higher blood flow rate. So that, because what happens with hemofiltration is the plasma or the fluid across from the blood compartment is filtering through the membrane, and then the blood actually is becoming more and more thicker and more viscous as the hematocrit actually goes up as the blood passes through the filter. And I need this, I can't actually continue to do this without actually replacing the fluid, because over a period of time this blood will get more and more concentrated, the hematocrit will go up and the blood will clot. So I need to replace, I'm replacing the bad fluid from in hemofiltration across the membrane. I'm sucking that fluid off in it, and because I'm sucking all that fluid off, I need to replace. So that's where the replacement comes in. So I can actually dial in anything that I want depending upon the patient. Now, if this patient has, in addition, say for example, developed rhabdomyolysis as well, in addition, say for example, came in with a trauma and had quite a bit of an ischemic limb, had a vascular injury, and he's went for a repair and now has muscle swelling, and they've done fasciotomy, have come back. What will be my way of treating this patient's hyperkalemia?
Need increase dose, increase flow rate.
Yeah, one is increase the dose, yes. But what mode do I use? I want, say for example, there's quite a significant rhabdo. What do I do?
You will use more convection.
So we need more convection. That's right. So I can actually do CVVH as such, but this patient also has hyperkalemia. So I can dial all as 2800 ml of CVVH is the right answer, but I may also use CVVHDF, where I can use more of, say, for example, 2 liters of replacement therapy and only 800 mils of dialysate, where, because again, I'm also trying to look after the potassium and the creatinine, and also want to take rid of that as well. So I can actually use that as a combination. So that's something that you can do. How high can I go to the dialysate? How much? What's the highest dialysate I can dial on the machine?
So we have gone up to 2 liters.
See, in our Prismaflex, you can go up to 5 liters.
Any other answers?
Yeah, we have used up to, I would say, remember, up to 3.5 liters also. I mean, the maximum limit I'm not aware, but as somebody said, it could be 5 liters.
So you need to know a machine, so you can dial up to 8 liters. So if you have, say, for example, life-threatening hyperkalemia, and you're doing have both limbs, say, for example, severely ischemic, you can actually dial up to 8. You can dial up to 5 liters of dialysate. The only thing is, you have to keep the nurse at the bedside, have to keep changing the bag every half an hour, or depending upon how much replacement we are giving. So you need 2 nurses at the bedside, just putting one bag in, taking the bag out. So you can dialyze the patient at much a higher rate, depending upon what I want to achieve. So it's not that only 3 liters is the enough, 4 liters is enough. People have used, I have gone and spoken to patients where they have used 2 machines, where they haven't even not optimized one machine's dialysis, and they've started to put 2 vas catheters because the lactate's been high, the potassium's been high, this patient's got severe abdo because of trauma, blah, 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 or ischemia. But you can actually dial up quite significantly high on the dialysis rate if you have resistant hyperkalemia and you're not achieving what your prescription is when you started. So yeah, so I hope this is a little bit clear, and this is something that Gunadhar, that you were talking about when you're thinking about the blood flow rate. The blood flow rate should be in CVVHD. The blood flow rate should be 2 to 2.5 times of the dialysate rate. And we need to, when we say dialysate rate, we need to calculate it in ml per minute. So when we say dialysate rate, so for example, in the prescription was 2 liters, but that 2 liters is per hour. We need to convert that liters per hour into liters ml per minute, and then make sure that if say, for example, 2 is 33 and 2.5 times is 83. So as low as 80 mils or 85 mils or 100 mils, if you're starting CVVHDF, even at a higher rate, in a very unstable patient who's on high inotropes, I don't want to increase the blood flow rate too high because he's on, say, 40 of NORAD, 0.04 of vasopressin, and he's hyperkalemic. I can start him on with that 100 mils of the blood flow rate. I can actually dial in up a little bit more of the dialysis. So if I go to 150, I can give him much more of the dialysate, and that way I can say, for example, in the lower, you can see the example. So with a rate of 120, I can actually make sure I can achieve the whole dialysis prescription if I'm just worried about hyperkalemia and the patient's quite sick. Whereas things get a bit trickier when I am using CVVHDF. So CVVHDF, if I'm using especially pre-filter, I need to make sure my blood flow rate is 6 times the pre-replacement fluid rate. So if my pre-replacement fluid is about 1800 mil, my blood flow rate should be at least about 180 mils. So that it depends upon how much my patient hemodynamically can tolerate the blood flow rates. I need to do that. But if I'm doing post-filter, the blood flow rate should be at least minimum 5 times. This is important because This is where the filtration fraction comes in. So the more blood flow rate, the more filtration that will happen, and I need to have a minimum blood flow rate for that filtration fraction to keep less than 25, and so that's important. So in order to maximize small volume clearance, I've started with CVV HDF. If I'm using this as a formula, and I have to make sure I keep an eye on those numbers. On a safer side, we start off at 120, between 100 and 120, but at the same time, I make sure I don't use too much of pre-filter dilution. So filtration fraction is important because it's especially important when I'm using hemofiltration, because as I was explaining earlier, what happens is the plasma and the fluid is going across the membrane. There's a solvent drag, along with that solvent comes across, and as the blood passes through, it becomes more and more viscous, and we need to actually replace that with a replacement fluid. Usually we use Hemosol. And again, I'll skip these diagrams. So we've gone through this. I hope it is a bit of, you understand what I was trying to say. You can dial in depending upon, again, what my patient needs and what I can change. So I can dial in any of these things in my patient with super hyperkalemia, and that will be my prescription that on an average may look like if I need the potassium to be cleared up, not only I need more dialysate, but I also need more blood flow rate as well, so that I can actually achieve higher clearance, faster clearance, and that can also clear the acidosis a little bit faster and help with the hemodynamics of the patient as well. So this is just an example of what I can do with one of these patients. Now, this is of these 5 options, which one do you think is most efficient in clearing the potassium? So I have a patient, option 1 is where the blood flow rate I've started as 180, the pre-PBP or the pre-replacement is 1800, and post-replacement is about 200, and dialysate is about 800. Option 2, the blood flow rate is less, but I've increased the dialysate. I've decreased the PBP. Option 3 is where it's more dialysate, a little bit of post replacement, and option 4 is where the blood flow rates come down, a little bit of PBP, more of the dialysate. So which one is more efficient in taking hyperkalemia or treating these patients hyperkalemia? I just want a relative answer. Can be anything. So what do you think?
Hello. For isolated hyperkalemia, you can just increase the dialysate only. You need only dialysate. You don't need any kind of convection at all.
So which option are you looking at?
Okay, I'm sorry, I'm driving. I cannot see the screen. I'm just listening.
So it's option 4.
Option 4, yeah. So option 4, where you have a lot of dialysate, you have enough to support the number. You giving a little bit of PBP. So yes, this is also as good as when you have. What's the problem with option 1?
Probably the dialysate rate is very low to clear up the potassium.
And
dialysate rate is very low, and maybe this 180 ml per minute of blood flow patient might not tolerate. Other than that,
the other thing is that you're also diluting the blood before it's going to the filter. So because this is PBP,
1800 rate will be much higher.
So even though the blood flow rate is higher, and we are allowing more blood to go through the filter, but we are also diluting that blood as well. So I'm not happy with that much of pre-dilution, because again, when you pre-dilute the blood, the clearance will also go down, and the dialysate is also quite low. So we may not achieve that hyperkalemia clearance, even though the blood flow rate is higher here because the PBP is much higher. I like this one where even though the blood flow rate is 100, there is no PBP, so there is no pre-dilution of the blood, and there's good amount of dialysis that's going on. Yes, there is some amount of replacement I'm giving as well. I'm quite happy with these as well. So yeah, we need to make sure that the PBP also affects on your clearance as well. So it's not that if you give too much of PBP and too much of blood flow rate, the clearance would be higher. You have to also look at what am I doing with that prescription as well. So
I have just one. I have just one.
yeah.
I think some network issue is there.
Yeah.
Hello. Yeah.
Yeah, the other thing is, if say for example, I have started a dose of 2800, the blood flow rate is 180, which means that mils per hour. And if you divide that, my filtration fraction is 25 or 26. What do I do next? What is the problem if my filtration fraction is quite high?
In that case, you have to have some amount of pre-filter.
The filter go
To
into
make it blocked.
Yeah, the filter will clot. So I need to make sure that my filter fraction is about less than 20 or around less than 25 if I can't achieve in very high dose. But I'll try to keep it around 20. If my filtration fraction is high, my filter is likely to block. And then I can blake or anticoagulation is not a problem, prothrombotic state. So how do I decrease the filtration fraction?
So you can increase the blood flow, or you can increase the pre-filter component of the things.
So if you can decrease the blood flow, once I decrease the blood flow, the filtration fraction will come down. Or will if I decrease the blood flow, will my filtration fraction come down?
No.
No. So how do I decrease the filtration fraction?
You need to increase your blood flow.
If you have to increase your blood flow, or I decrease my ultraflow rate, or increase the dosage that I'm giving.
You need to increase your CRRT dose.
PBP
Either you need to increase your blood flow, or you need to increase the CRRT dose.
or if you can,
Dose.
decrease the dialysate and replacement rate both together,
Yeah.
and that also can decrease
So
the
yes. So the dialysate rate doesn't actually affect much. It's the ultrafiltration rate or diafiltration rate that you need to actually come down. So you need to, it's not that pre-filter will help. Yes, it may help, but again, I need to make sure that the proportional blood flow rate is 6 times. So I need to here is increase the blood flow. If the patient can tolerate, increase the blood flow rate or decrease the dose for some time. So if my filtration fractions is normal or is high. Let's go to this. We have discussed this a little bit in the previous slides. So we have a 58-year-old female.
Can we take some certain questions, because there are a few questions which are there in the chat box basically, sir.
Oh, sure.
So,
What are the questions?
So there are 2-3 questions, sir. Somebody has asked about the dialysis catheter. The 15 centimeter, what is the ideal size of the dialysis catheter? He is asking basically the 15 centimeter for right and the 20 centimeter for the femoral. Is it enough, or there is some specific size that is needed for the dialysis catheter?
I think 15 centimeters for the neck right IJs are fine. There are times it also depends upon how tall your patients are as well. If your patient have a long tall catheters, and if we tend to actually place long catheters for a patient who needs ongoing dialysis and have flow issues, where we have put and we have allowed the tip of the catheter to be in the right atrium. So we have at times used 20 centimeter ones in our unit, especially in our taller patients where we don't achieve and they don't reach the cable and the atrial junction. So, and yes, so we do only stock 20 and 15 centimeters. If we need more than 25 ones, we then go to the renal unit, get special long one catheters as well. We have certain 25 centimeter catheters in the unit as well, but we don't use that. For femoral, yes, 20 centimeters.
Questions.
Yes.
There are
15
questions asked to Dr. Govil also. I mean, if Dr.
Yes.
Govil is also available, sir, would you like to answer these questions?
Yes, please tell me.
There is one question.
Sir, yeah.
For
So-
sepsis, they've asked a question like whether CBVHDF along with the CVHD, if the potassium removal can be facilitated with this, or we should use something else. This is one question that
I think Dr. Manoj has very well explained how the potassium goes out. It goes out very well in the dialysis. So CVVHD, it goes out. But if we are using CVVHDF, certainly it will go out, potassium will go out. So that is not a challenge.
Sir, another question is for like, what is your take on, sir, blood purification with CRRT, sir? Nowadays, this is one of the recent concept of sepsis.
We are using different sort of filters for last 13, 14 years. And gradually our faith in those filters are fading away. Simple reason being, in that many period, I think we have used more than 1,000 cartridges till now of different make. Maybe it's a Toremixin, Cytosorb, Oxaris, and this one or two other companies, I forgot the name. What was that? But the problem is that we could hardly demonstrate any mortality benefit. And using these filters just to prolong the life is sometimes not so cost effective. But again, it's a gray zone. I can't definitely say that you shouldn't use, and I can't say that you should use. Certainly, they are not a standard of care, but in a desperate situation, if you are using, please use them as early as possible. If you intend to use them, use in first 24 hours, as the definition of early dialysis is within 24 hours of AKI. I would say if you want to use these adsorbent or any cartridges, any filtration method, please use in the first 24 hours. Beyond that, I don't think that they are going to work.
And these filter usage was guided by the biomarkers.
They may be guided by biomarkers, like you can use the endotoxin assay and cytokine assay, or especially those places where these markers are not there, we want to use, you can use on your clinical terms as well. First 24 hours, refractory shock with some other organ failure, like 2 organ failure with shock, I may use these filters where we know that it's a cause of the shock is sepsis.
So do you do routinely, sir, endotoxin assay in your hospital, sir?
Not routinely, but in those patients where we think that this might help, we do the endotoxin assay. So as you can see, as I can say that we use endotoxin assay as a screening tool, as an enrollment tool, or enrollment is not a right word, but as a screening tool to use these filters.
Any role of presepsin monitoring during the filter usage in CRRT?
What, sir? What, Dr. Akhilesh?
Presepsin monitoring.
So that is also some kind of biomarkers, no?
Yeah, this is also biomarkers. Yeah. We had this machine employed in our hospital. We have a data of 25 patients monitoring presepsin levels, but we couldn't.
No, we have not done. I don't have got that machine, so I can't do the preseptin level. I have never done it. I don't
Can
have.
I make a comment on that?
Yeah.
Why not? Please.
So, regarding the presepsin uses, actually a couple of years ago, pre-COVID, we were using this biomarker. And if Akhilesh has mentioned about it, you must be aware about those 2 papers. One was a single center. I think those 2 papers were from single center studies only. So the, in septic shock or the severe sepsis, which was the term used on those times, the level of presepsin used to be very, very high in the first 24 hours. Afterwards, it did not have, the trend did not reflect much, it did not correlate with the outcomes, as opposed to procalcitonin that we know that the trends do help, and it is suggested in many studies. It has been approved in many studies. And regarding the usage of these blood purifications for sepsis with more of this endotoxins, we always found, there is dubious results. And there was a small, letter we had written regarding this usage of cytoserv in septic shock patients. It's a friend or foe, because the very physiological principles that by which we expect that these absorbents, cytoserv, like these absorbents will absorb the bad cytokines of the inflammatory mediators. They'll also might, they do not discriminate between good and bad antibodies or the marker inflammatory mediators. So they might as well absorb the good ones also, which are really protective for the body immunity to sustain, right? So just based on these basic physiologic principles, I think most of the studies across the world, if you see, and across all continents, they have failed to establish any evidence whatsoever for this kind of blood purification therapies in the last 1 decade. Yes, recently regarding this toxin removals, I would say something. I think the different kind of, the membrane surface area which is available, that is one something we have found useful in clinical practice. But as far as their usage in sepsis and septic shock is concerned, I think it has, failed to assume any place in the standard care of therapies.
I would like to ask Dr. Milind also, what is his view on this endotoxin filters in Australia, in his institute?
Yeah, look, good comments coming from everywhere. Personally, what we don't use just for the sepsis, for the removal of the toxins, but often these patients with the sepsis and septic shock, when they come, they are likely to have other indications as well. A lot of them are going to have renal failure, and then with that maybe hyperkalemia, anuria, and for those group of patients, initiating renal replacement therapy early is useful. And whether that is helping to remove the toxins or not, we don't know that. But at least I will have low threshold to start the renal replacement therapy. Yeah, but just not only for the sepsis reason. I completely agree that they are going to remove the good and bad toxins. But I will have low threshold to start.
Dr. Iyer sir, do you have any views on this? Dr. Shiva Iyer sir, if you're here. Okay, I think we have tried all the questions. We can go ahead, Dr. Manoj. Yeah, please, thank you.
Okay, so only thing with the Osiris filter is if you want to use it, as Dr. Govil said, you need to use it early. And most of the evidence is around using in the first 72 hours. So if you use it for the first 72 hours, after that, you need to actually go back to the standard filter if the patient requires ongoing dialysis. You can't just keep on going them forever with these kind of filters. And again, Sharmili also rightly pointed out, we need to be careful about what we are sucking out, what we are absorbing. We are not just absorbing the bad cytokines. There are other kinds that we are also absorbing.
Can I make a small comment about the bad and good cytokines, if you permit?
Yes.
So as we go on this discussion, what are the bad cytokine and what are the good cytokine, and which is going to be absorbed or removed by these filters? Mind you, the ideal time of these filters usage is when there is a cytokine surge. And if you remember the anti-inflammatory and inflammatory cascade in first 24 hours to 48 hours, majority of the patient, if they are surmounting any inflammatory response, they go into hyperinflammatory response. And that is the right time to use these filters. If your patient is in the hyperinflammatory phase, then they are going to benefit theoretically. And if their patient is in the more of this anti-inflammatory phase of that graph, then certainly these are going to harm the patient. So we have to clinically decide, or by the biomarkers like the cytokine assays, in which phase my patient is there. And as Dr. Manoj rightly said, the company says 72 hours, but in my experience of last 12 years, I find that if it is working, it's working in first 24 to 48 hours. Beyond that, I flatly say that no way. You are going to waste your 1,50,000 rupees. I am not going to use it.
Yeah.
That is my take on. It's my experience, whether you take it or whatever you feel about it. Thank you.
Sometimes it is very difficult to assess whether it is cytokine storm or endotoxin.
Exactly, Akhilesh, because we have seen in COVID times, like, your markers will be hayward, the patient will be looking good, and sometimes the patient is so sick and you do not get, the biomarker levels also may not be obtained on time depending on the center you are working. So it's always a difficult call.
Probably in that situation, we have tried a combination of filters as well, some cytosol filter along with oxalis filter, but we couldn't achieve much probably. But we need to have a data pertaining to this, and then only we'll be able to conclude. Even sepsis guidelines have not recommended use of filters for renal replacement therapy. It is the multimodal therapy that is going to help us, the clinical assessment, the hemodynamic optimization, and the source control. All that is also very important, not only the filters.
Can we go to the case 2 and I think
Yeah.
that is more interesting.
Yeah, please go ahead, sir. Yeah.
I'm skipping the case 2 in interest of time. I'm going to case 3. So now case 3 is a 65-year-old male with 70 kilos. Again, it's just standard for calculation. Has an AKI, post AAA repair, had a ruptured AAA, had a AAA repair, now has come with significant AKI. Is shocked, vasodilatory shock, has quite his blood pressure is bad, is on high dose noradine, 0.4 of vasopressin, had massive transfusion initially, is an FiO2 of 1, his potassium is 7.6, has a bicarb of 6. As you can see, he's got severe AKI, his lactate as 18, his urine output is 5. How do I prescribe this patient CRRT?
So probably he will be a candidate for early CRRT with acidosis, hyperkalemia, oliguria. I would like to start with CRRT because he's on high dose of vasopressors, dual supports. And basically in this patient, I will like to keep the blood flow on the little bit lower side, around 80 to 100 ml, with a dialysis rate of, I'll start with a dialysis rate of 1 liter with replacement of 1 liter, and I like to use regional cited anticoagulation in this patient because I anticipate he might go into coagulopathy. And then my filtration fraction I'll try to keep between 25 to 30%, around 25%, less than 25%, with the effluent rate of around 35 to 40 ml per kg per minute.
So when you say you want an effluent rate of 35, so I need to calculate my effluent dose, that is 35 into 70. So what is 35 into 70 if somebody has a calculator?
It'll be around 2400 or like that. Around 22.
2400, yeah, absolutely.
So now if you say 75 into 70 into 35, you said. So yeah, 2400, or we can just say 2500. So of which you said you only at the moment your whatever prescription you are doing is less. So because you said you're doing 1000 mils of dialysate, 1000 mils of replacement. So you're only giving 2000 mils of the total dose. So you need to, whenever you do that, you start off with the mils per kilo, multiply into the weight, and then say of which how much I want dialysate, how much I want replacement. So I want, say, do you want more of dialysate on him, or you want more of replacement or ultrafiltration on him? What do you want?
More dialysate because his lactates are high and his potassium is also high.
Yes, so I want a dialysate of 1500 and a replacement of 1000. Yeah. So basically in this acute phase, what I want is to correct the patient's potassium. That's my main goal. Otherwise, this patient will arrest soon. So I need to dialysate. I can even start off with a higher dialysate as well, or I can start off with a dialysate of 2 liters and then 500 mils of replacement. This is only for the first 3 hours, 4 hours, when I'm trying to actually get on top of the patient's potassium. When I start off with a higher dialysate, when the patient is hemodynamically unstable, I can afford a lower blood flow rate. I don't need a higher blood flow rate as well to start off with. At the same time, I'm trying to actually clear that patient's potassium. Now, why is this patient's potassium so high?
It's probably the transcellular shift because of the acidosis, or probably because of the DIC, might be.
And he has also received massive transfusion blood transfusion.
Massive transfusion. What
And
else?
he had a AAA repair also. So could be, thrombosis, ischemia of the limb.
Yeah, it could be ischemia of the limb. We don't know when he had a ruptured AAA. What was his perfusion to his limb?
Limbs.
And how long did the clamp time was? Where did they clamp it? So whether the clamp time was more, whether there is significant ischemia, has he developed more rhabdomyolysis, and rhabdomyolysis is the cause for his hypokalemia. So in the initial phase, I can actually put as much as dialysate I want for this patient, for his potassium to get into a safer limit, and my prescription can be anything like this, depending upon the hemodynamics the patient. So I need to be standing next to the bedside. I can't just prescribe one numbers and then go for 12 hours and come back and look at what his potassium is doing. This is a patient who has an ongoing dynamic issues. I need to be a bit more dynamic, like what we do with ventilation at times. If there is a difficult ventilation, ERDS ventilation, we stand at the bedside and then dial in, see this is better, that is better, this is getting better or not getting better. So I can actually go up as much as dialysate of 6 liters because this patient has quite a significant hypokalemia issue. I can dial in my blood flow rate a little bit lower. If start off with a lower blood flow rate and see, I can dial up the blood flow rate higher if with the same amount of dialysate, and see if I can clear more of the blood with that same issues. I can use any of these. So these are the maximum rates that you can use. You can use an effluent rate of up to 8 liters depending upon what you want. But yes, what I mean to say is you can actually don't start off with a standard prescription of 1,000 and expect a magic to happen over a period of time. So you need to make sure, what am I doing? Is this prescription tailored to this patient's problem, and then go from there. So yeah, so 12 hours later, the same patient has a CK of 32,000. Now, how do I modify my circuit?
So we'll reduce dialysate here.
So now the potassiums come down to 5.6. Bicarbs improved, urea creatines got a bit better, lactates come down from 18 to 6. Urine output is still anuric because he's got an AKI, he had a long clamp time and was hypotensive for a long time. Now, 12 hours later, you do a CK is 32,000. What do I do? How do I change my prescription?
So here we'll reduce the dialysate, and we may go for isolated CRRT without removal of ultrafiltrate, because patient is still on NORAD and vasopressin optimum dosage.
Yep.
Probably if we can get rid of these vasopressors, later on we may think about fluid removal also, because the lactates are still high. Lactate is 6.
So will you stick on CVVH-DF or you will change CVVH? What do you want?
So here we will switch over to CVVH.
So we will switch on to CVVH. Any other answers?
I would like to, we can continue with CVVHTF. You can make it, just zero balance. And as you progress, keep on monitoring the metabolic status. As you progress, you can, because you are also, giving at least some feeds or other injections must be going on. So after assessing the volume status, you can gradually start, making it a small negative balance, like say 50 ml per hour or 100 ml per hour, like that. So I would be happy to keep it with, CVBHTF with zero balance to initially, and modify as you progress. Yeah.
I will also do the same thing. I will continue with the correct modality of CRRT.
So yeah, so if you want to CVVHDF, so how much dialysate will you dial in, and how much replacement will you dial in? Will you keep it at 2,000? Will you keep it? So for example, we started 12 hours ago with a dialysate of 2 liters and replacement of 800 mils. Will you keep the same?
You can decrease the dialysate.
Yeah, here we can decrease the dialysate.
So how much do you want to decrease the dialysate to?
So from 1.5 liter to I can come down on 1 liter.
So 1 liter. And what about the replacement?
The replacement also same, around 750 to 1 liter.
So you will increase.
Replacement we might increase or we may continue with the same, but definitely dialysate we will reduce to 1.2 to 1.5.
So how will you get rid of the CK then?
So
So
it is,
now, if you have a myoglobin circulating in your body, in your blood, it is also, we need to get that myoglobin out. So how I'm going to get the myoglobin clearance in this patient?
Again, in that case, you need to increase your replacement only.
Yeah, so we need to do ultrafiltration. So we need to improve the ultrafiltration, because again, unless I remove the myoglobin, the patient's recovery will not be earlier. In this case, yes, because his potassium is nearly normal, 5.6 fine for his situation. I need to now increase the replacement as much as possible and maybe slowly decrease the dialysate. So dialysate can come down to 800, and the ultrafiltration or the filtration can go up as much as, because as I showed you the first graph, as I go up on the molecules, I need more hemofiltration. And hemodiafiltration is somewhere in between, which is the best of two worlds. But I can actually change my prescription to CVVH completely, where I can all do is 2800, 3 liters, 4 liters of the hemofiltration, so that I'm not trying to get rid of the myoglobin, because unless I get rid of that myoglobin, bring that myoglobin level down as early as possible, the recovery for this patient's renal recovery will be more and more delayed. So here my potassium is not my major issue. Yes, hemofiltration can also take care of the potassium. It can create the acidosis clearance. It can take care of the creatinine clearance, but myoglobin is my main worry here now. So I need to make sure I dial more hemofiltration, more replacement, more component of the hemofiltration than the dialysate. Dialysate is not that important at the moment. So there are times where there are certain units which only do CVVH in as a starting mode, and they don't do much of dialysis. So it depends upon what people are comfortable with. And so did you understand the basic crux of that case scenario? How do I modify? What am my first goal is? What is my second goal is?
Just one comment, can I?
Yeah.
More for the DNB candidates. I gather there are a lot of DNB candidates as well. So we discussed a couple of times the prescription. So particularly in the exam setting, when the candidate is asked the question how you are going to prescribe, that was Manoj's first question. So what is expected is they give the full answer, which is what it means is what modality of dialysis or filtration you are going to use, whether it's CRRT or IRT. If it is CRRT, what filter you are going to use, what is the dialysate, what is the filtration, blood flow, dialysate flow, and your technique of anticoagulation. So that is all expected, and that's what very good discuss in two examples. So just the reminder.
Yep. Thanks, William. So yeah, so case 4, I hope I'm not taking too much of your time. So case 4 is now the same patient, case 3 patients now 3 days, 4 days down the line. He's still in anuric renal failure. He still requires ongoing dialysis, and he's having repeated clotting of his circuit. So the filter is getting clotted multiple times. He's on inotropes have come down slowly. He's on low dose NORAD, vasopressin's off, but he's needing ongoing dialysis because he's anuric. But each time we start, the filter clots. So what do we do? What are the
we will increase the blood flow. If the vasopressor requirement is coming down, we can increase the blood flow, and we can increase the replacement also, which will increase the shelf.
But the problem is the filter is getting clotted. Each time I start a new filter, circuit, it gets clotted. So what do I do?
Sir, I would like to know what modality of anticoagulation you have used in this patient.
So far, I had not used any heparin. So you can use heparin. You can start an heparin circuit, but you started heparin circuit, the surgeons come and say, I'm a bit worried. We had a big perioperative hematoma, did surgery, blah, blah, blah. But yeah, you can try low dose heparin, but the filter is still clotting.
So is it a regional anticoagulation have been used in this patient? With
Yeah, you
calcium?
can use regional anticoagulation. And what regional anticoagulation you want to use?
We are using citrate most of the times.
So you use regional citrate. So everybody uses citrate. Anybody who doesn't use citrate?
So probably the first thing is to monitor the anticoagulation efficacy, like whether the calcium in the circuit is okay, whether the citrate load which is coming to the.
That's fine. Before you go to citrate, anything else will you look into?
Yeah, so one thing can be modified, like doing means instead of the replacement in the post filter, we can keep in the pre filter actually.
So you can look at the filter. You need to make sure the vascath is good. There is no kinking. The vascath is, you're aspirating well. It's not patient issues. It's not vascath issues or the access issues before you change the filter. And yes, so basically something that you can look about is citrate. You need to understand the indications and of citrate. There are certain contraindications or relative contraindications of citrate as well. We don't use in patients with liver failure who have citrate intolerance or has severe hypocalcemia to begin with, or have some kind of chronic liver dysfunction. I'll just skip this part. And so yeah, so you need to make sure when you do citrate, the bags that you use are a bit different. So the citrate bag goes in the PBP pump, because as soon as the blood comes out of the patient next to the vascular, the PBP the catheter goes all the way to the vascular, where the citrate is then mixed, and it's about a 1 centimeter long tube before the filter. The anticoagulation effect is achieved. So what citrate does is it chelates all the calcium, and by the time it reaches the filter, what should be the calcium level, ionized calcium level?
So in the range of 0.8, around in the range of 1.
So 0.8 to 1 is the kind of low end of our ionized calcium in the body. So what should be when we're going citrate, when we are mixing citrate into patient's blood, what should be the ionized calcium level before it reaches the filter? Because we are now anticoagulating this blood before it reaches the filter. So if there is a pre-filter knob, a sample port, if I do a VBG on that, what should be the ionized calcium on that VBG? So to have an anticoagulation effect, what should be the ionized calcium? Should be less than what?
Less than 1.2.
Yeah, less than 0.5. So it the depending upon what dose you're giving or citrate, the level can be somewhere 0.2 to 0.5. So this is now because the PBP, the citrate bag is there, it's mixing with the blood, it's chelating all the calcium, the ionized calcium is going less. So by the time it reaches the filter, the ionized level would be less than 0.5. So it's anticoagulated, and you have an anticoagulated blood going through the filter. Now you're having a calcium citrate complex that is going through the filter. This again, 60% or 70% of this calcium citrate molecules actually get filtered off. And as we go up 32 or less than 30%, 22 to 30% actually go back into the patient. Now, when this patient's blood is getting returned, it has a calcium of or ionized calcium of less than 0.5. Now, when it goes into this patient, an ionized calcium of 0.5, what will happen to the patient?
Severe hypocalcemia.
Severe hypocalcemia. When the patient has severe hypocalcemia, it can be life-threatening. You can have tetany, you can have laryngospasm. So we don't want these patients, and it will also cause systemic anticoagulation to the patient. So to prevent that from happening, we give them calcium replacement. So this calcium replacement goes back, and we make sure when the blood goes back to the patient, the ionized calcium is back to normal. So it's about 0.8, 0.1 or 1.1. So we actually do a VBG in an hour's time, ABG in an hour's time, make sure the calcium levels or ionized calcium levels in the ABG is normal. And we often titrate. We don't titrate, but the machine automatically calculates the rate of calcium replacement based on your blood flow rate. Higher the blood flow rate, the higher the citrate the machine will deliver. We can also titrate the dose of the citrate in this patient, depending upon, you can dial somewhere between 2.5 to 3 millimoles per liter. So you can also dial the citrate dose as well. So it is important to understand that how citrate works, how much the citrate comes out. Some of the citrate goes back, calcium citrate goes back. And this is why the liver is important, because liver is the area where the calcium citrate is metabolized. Is citrate an acid or a base? Calcium citrate an acid or a base? It's an acid. So now if my liver is not working or the patient's liver is not working, calcium citrate will start accumulating in the body. And paradoxically, what happens, you're starting a patient on dialysis and his, over a period of time, his acidosis is getting worse. So you say, oh, what's happening? Is the patient getting worse? We need to dialyze him more. We increase the blood flow rate and you're giving him more calcium citrate, and the acidosis is getting even more worse. So you need to understand that as well, that in a patient with significant liver failure, that's why we don't actually start them on citrate dialysis, because it can paradoxically worsen their dialysis, worsen their acidosis by accumulation of calcium citrate if it doesn't get metabolized. But yes, when it gets metabolized, calcium gets released and it gets, the citrate component gets metabolized into bicarb, and you can have the other end as an alkalosis as well. So you need to make sure when you're on citrate dialysis, the dialysis doesn't have any calcium, and the replacement fluid is mostly what we use as the hemosol. So have you understood? I don't have much time to explain the citrate dialysis. It's a talk in itself. And how do I diagnose citrate toxicity, blah, blah, blah. I'm just skipping all that. And maybe
he has to leave.
Yeah.
We have 5 minutes more, I think. And
so yeah, if you have any questions, I can answer that. Otherwise,
thank you, Dr. Sharmiti, for your presence and your wonderful insights.
Thank you, Akhilesh. It was a real absolute pleasure, and thanks, Dr. Manoj, for excellent moderation. I would say I was enjoying throughout, but I have to leave for another meeting of our branch. Actually, thank you very much.
Sure. Thank you.
And Dr. Milind and all others who are part of this meeting. Thank you.
Thank you, Chairman. Thank you.
So maybe in the 5 minutes you can ask me questions. I'll not go through more scenarios.
So there are one or two questions in the chat box basically. So one thing is role of bivalveridine in this anticoagulation of the CRRT circuit. And second question is asked by Dr. Amol. Dr. Amol is from Tata Memorial Center. So his question is like
citrate is a base, probably he said.
So yeah, calcium citrate is an acid. Citrate itself is different.
So you have any experience on using bivalveridine, sir, for the anticoagulation of the?
Sorry?
For the bivalveridine in place of heparin or low molecular?
No, we don't use that. So only if you have significant hits, and even if in the hits we use citrate. So citrate is our go-to therapy unless there is contraindication where patient has significant liver disease. Then we occasionally go to those kind of anticoagulation.
So can I say something?
Yeah.
Majority of the liver failure, we are using citrate for last 6-7 years. And it works very well, because the liver failure patient, be it a acute liver failure, be it a post liver transplant, their coagulation profile is quite deranged. They are side by side, they are hypercoagulable as well as the hypocoagulable as well.
Yeah.
So CRT circuit clots very easily in those patients, and our experience with citrate is very good. So almost 99% of the CRRT we are doing with citrate. We are doing close to maybe 20 CRRT in a month, 15 to 20 CRRT in a month, and out of them, almost 99% are with citrate, unless in some patient the citrate is getting accumulated or something. In those septic patients, septic shock patients where lactates are too high, so if the starting lactate is somewhere around 20, 25, in that case, we certainly try to not to use the citrate. We start with heparin and sometime very less heparin. But biliverdine we have not experienced. We have used this biliverdine in certain VV ECMOs, but not in CRRT. But certainly it can be tried, it can be used. I don't know. It gives me an idea to start a pilot project in using few patients.
Well, I can comment. We also go for the most of the time, but I have used biliverdine as well, particularly here in the patient group if they have hits and they have got additional thrombus somewhere, and you require not only the local anticoagulation, but you require systemic anticoagulation. So those settings I have used.
How much is the
Dr.
duration
Milind,
of the filter?
what dose you are using? What dose you are using?
Well, I can't recollect the dose right now.
It's okay. I was just thinking that can we start in a pilot? I'll go through the.
But we have the protocol. So
can I connect with you offline for that protocol if you don't mind?
Yeah.
Okay.
Sir, another question is for somebody has asked for in non-renal indication of CRRT, sir, like in malignant hypothermia, in liver failure, and one like anaphylactic shock, sir. What is your take on this, sir? Because sometimes,
malignant hyperthermia, you want to ask me or Dr. Manoj or Dr. Milind?
Sir, you can start.
So liver failure, of course, liver failure, it is a very, we use it very commonly in acute liver failure or acute and chronic liver failure. And as far as the malignant hyperthermia is there, certainly it can be used to bring down the temperature because there is a lot of temperature loss. The fluids are at the room temperature, and ambient room temperature in most of the ICUs around 22 to 25 degrees centigrade. So you can appreciate if I am doing a high replacement or high ultrafiltration dialysis like CVV-SDF or CVV-HF in those patients, then the temperature comes down very quickly. But majority of the time, if malignant hyperthermia is there, we use these Arctic sun to do the hypothermia, not the CRRT, because of the cost constraints are there. With CRRT, lot of hemosol is being used, so cost goes very high, maybe up to 60,000-70,000 per day if we are trying to bring down the temperature only. Acute liver failure, of course, it's a very good indication. And third, acute liver failure. Hello.
Sorry, we lost you.
I think your connection is lost.
Hello.
Sir.
Yes, sir.
Carry on, sir.
Yes, sir. Connection was lost in between.
Yeah. So, what was the third condition you said?
Third is like, sir, in case of anaphylactic shock or where the cytokine or any condition where there is high cytokine storm.
Oh, high cytokine storm is we already discussed as a use of the filters. But a standalone CRRT, there are plenty of studies which says the standalone CRRT is not going to benefit in that situation. Probably if you are using some adsorbent or auxiliary type of filter, that may be a little bit of helpful, whatever it is.
What about the role in the lithium toxicity? We had quite a few patients.
Sorry, I don't have got any experience. I don't foresee any. I have not experienced any lithium toxicity.
Dr. Manoj Singh, you have any experience of using CRRT for lithium toxicity?
We use independent analysis for most of those patients. Yes, we do use at times if they are not available. then we do use CRRT. It also depends upon whether it's an acute poisoning or a chronic poisoning, the levels whether correlate or not correlate, and so you need to be a bit careful with those.
Well, lithium toxicity, whenever I have used, mostly in the acute setting, is the hemodialysis rather than the CRRT.
Intermittent. So we go for intermittent, but there are times where a patient comes in middle of the night, we can't get an intermittent dialysis filter. We do start them on a high dose as a prescription, as a dialysis. As I was showing, as I was telling you or explaining, that we do dialyze them with a very high dialysate rate and less of the filtration rate.
Yeah. If I have a patient with
You
the
can still do it
flu,
overnight.
Yeah.
If you don't have it an intermittent dialysis available.
so my question to all the panelists, if I have a patient with the acute fulminant hepatic failure and if I have to go with the CRRT, what would be the best prescription that I would have? So Dr. Manoj, from you, if you can initiate.
Yeah, Dr. Govil, you want to talk first?
No. My view are little different. If I am having acute liver failure, I would rather go for a plasma exchange rather than the CRRT. So my first modality will be the plasma exchange, and if I am requiring the renal support, I'll do the CRRT along with the plasma exchange in the same circuit in a series.
Yeah.
So, but what are the indicators to start CRRT? Is it the renal failure or is it the volume overload?
No,
Yeah, please, Dr. Manoj, please.
Yeah, so in acute liver failure, it's you don't have to wait for the classical indication for renal replacement therapy. It all depends on your ammonia level. What's the opening ammonia level at presentation? If the ammonia level is quite high, you start CRRT no matter what the creatinine is, what the pH is, even the pH is normal. I would start CRRT just then as soon as the patients come in, because what you want is to bring that ammonia level as down as possible, as early as possible in these kind of patients. And there is a good study from from Australia where they have compared patients who's come with acute liver failure, and this is what's on the slide. They start CRRT as early as possible, and they have compared the outcomes of patients with low ammonia and high ammonia. And what they have demonstrated is if you bring the ammonia level as quickly as possible, they have a better outcome. Even post-transplant outcomes are much better in these patients. So the goal of renal replacement therapy in acute liver failure is just targeting the ammonia, nothing else.
The CRRT can also be accompanied with MARS as a bridge to liver transplant in such patients if they are presenting.
We don't use MARS at all.
I'll tell you, we use sometime MARS. The MARS is having inbuilt CRRT. So to talk about the MARS, it has got two filters. In the first filter, there is a bridge between blood and the albumin. And in the second filter, there is a bridge between albumin and the dialysate fluid. So it is combined, the same machine, like MARS machine cannot be used standalone. It has to be combined with the CRRT machine only. So these two machines, they can, when you combine both the two machines, then it becomes a complete circuit.
And how long the MARS can be continued?
It depends on the patient to patient. Till the filter is working, you can continue. Majority of the time, we can continue it up to 14, 18, even 20 hours. After that, there is a charcoal filter which absorbs the toxins. That becomes denatured. And from black, it becomes white. And that time, it's not going to work. Basically, as Dr. Manoj has said, the ammonia is the one of the biggest indicator in acute liver failure, because the ammonia which is causing the brain edema, and that's how the patient is like having the brain death or herniation. So our whole aim is to bring down ammonia as fast as we can. The MARS could be one, this plasmapheresis could be one, CRRT could be one, and single pass albumin dialysis could be one. In single pass albumin dialysis, in dialysate, we make the dialysate as a 5% albumin. So you put up the albumin in that, but the problem is that that albumin goes down the drain. It is not being regenerated. In the Mars, that albumin is getting regenerated.
Sir, another question
So
is like,
can I comment on this topic regarding this use of, there's a lot of controversy that goes on the use of plasmapheresis versus use of CRRT. So I think every center has a different experience in the role. So if you talk about our center for acute liver failure, uh, I do agree with Dr. Deepak Govil that the plasmapheresis is a class 1 indication in acute liver failure, especially high volume plasma exchange. But the problem of plasma exchange is that whatever the studies that we have got so far is that your exchange volume needs to be really high to have that effect. And second thing, that to have that amount of exchange, almost 4 to 5 liters per in 2-3 hours, it causes lots of hemodynamic disturbances now. And one of the biggest factor that we have seen in our center after doing a plasma physics, we have seen the biggest risk factor that we have seen is the infection. So most of the people, especially if we do a plasma physics in the setting of ACNA, they'll end up in the bloodstream infection or a kind of septic shock. So that is one of the major contributory things drive probably, that is why probably do not use plasma physics very often. But as Dr. Govil has rightly said, is that plasmapheresis is one of the class 1 indication in acute liver failure. But in our center, we mostly use CRRT in acute liver failure, but especially somebody who has a kind of coagulopathy, a high INR, where patient has already been listed. I want to intend a transfusion, I have to give FFP. Probably in that case, I would prefer to have plasmapheresis as well. So
I think
it's not only plasmapheresis, it's the plasmapheresis followed by the CRRT as a kind of continuous care.
yeah, I think Dr. Govil is very good experience in this treating the infection in post plasmapheresis, and I think sir can explain basically in
If the time permits and everybody permits, can I take it from the start?
Sure,
What
sir.
happens in acute liver failure? There are mainly 3-4 problems which we deal in the acute liver failure. One is the deranged INR, the hallmark of any acute liver failure. Second thing comes in the high bilirubin. Third thing is high ammonia. And fourth thing is, along with this, the cerebral edema or encephalopathy. Cerebral edema is encephalopathy. They are hand in gloves. They come together almost. So if you look at these 3-4 things, plasmapheresis becomes a logical choice because it will correct your INR. It will remove the albumin, remove the bilirubin fastest than the CRRT or Mars, and it will remove the ammonia as well, because ammonia is a highly plasma soluble thing. So either you are doing plasmapheresis or you are doing Mars or you are doing simple CRRT, ammonia will go down to the drain very fast because it's a highly water plasma soluble or water soluble. So it comes out very fast. These 3-4 things are there. As far as the literature is there, I understand there is not very hard literature, but if you monitor, if you follow the Western world, majority of the centers, they are gradually moved from CRRT and Mars towards the high volume plasmapheresis. And I forgot the paper which was published 4-5 years back. In that, they have shown some mortality benefit also. After that, the suddenly thought process changed towards the plasmapheresis. And as we talk about the high volumes, we are using almost 40 plasma bags in a single day. And generally we do alternate day because it takes 8 to 10 hours. That's why we shifted from blood bank people to doing ourselves, because blood bank people, they don't want to do that much of lengthy plasmapheresis. They want to finish it off in a 2 hours or 3 hours job. But it takes almost 8 hours to finish 40 plasma bags. But certainly results, I am happy with the results, and our center has gradually changed. As far as the sepsis and infection is there, it is what I'm sure that my feeling is, I may be wrong, I'm not sure, but my feeling is that this myth is being created by the surgeons, majority of the places. They unnecessarily blame one or other thing to the sepsis. If you remember, how can a plasmapheresis cause infection or flare up in the sepsis unless we are breaching some asepsis while changing the bags of the plasma or while connecting or disconnecting the circuit? Third thing which I would like to highlight here is, after each plasmapheresis, please load your patient with antibiotic again, because all those protein-bound component is gone down to the drain. So all those antibiotics which are to be loaded, like meropenem, you have to, like your teicoplanin, you have to load them again after each plasmapheresis. that is the cost we have to pay, extra cost for the therapy we have to pay. There was
I
one.
agree with you, sir. I agree with you.
There was one more point which I forgot. Yeah, about the fluid overload. Fluid overload, if you make a almost equal balance in your plasmapheresis, fluid overload cannot happen. Certainly in few patients, we have seen the taco and trolley. That is unavoidable thing. And if you are feeling taco and trolley, please don't go for plasmapheresis next time. Either go for Mars or single pass albumin dialysis or simple CRRT, which one you are having expertise.
Sir, one more discussion for our DMB students, like drug dosing in CRRT, sir, to Dr. Milind, Dr. Manoj, and Dr. Kobil, sir. Because this is very important, because most of the times we don't look after this.
Drug dosaging is very important. We underdose sometimes while the patient is on CRRT. How to optimize the drug dosages as far as the antibiotics are concerned?
If you want me to start the discussion now, it is complex and it's very controversial topic actually. The dosing, particularly of the antibiotics during CRRT, and again, because of the pharmacokinetics of the drugs, there is high risk that during the dialysis and filtration, those again, the effect of the drugs are removed through that, and we may be underdosing. At the same time, the patients have the renal failure. So often the patients with the renal failure, we tend to decrease the dose of the most of the medication. So should we keep the higher doses or lower doses, or what should we do? That's the question. I tend to keep most of the drug dosing same without changing. What most of the antibiotics, tazocine or ciprofloxacin, or quinolones, or meropenem, vancomycin, keep the same dosing. Whenever possible, infusion like vancomycin also. Also assess the clinical response of the patients. And if they're clinically worsening, then definitely I don't try to decrease. In fact, either keep the same dosing, keep optimal, consider to add another antibiotic or so. So definitely short answer is not to decrease the dosing. That's a big change. With the renal failure, we tend to decrease the dosing, while when they are on the CRRT, at least keep the same dosing. That's what I do.
So Dr. Manoj, like drugs like cholesterol and meropenem, which are very important for the patient. So
no, I think we have to go through levels, and again, it depends upon the dosing that you are doing on the CRRT as well. So if you are doing a high dosing, if you're using more convection, then the drug level often actually is how you monitor whether whatever dosing regimen you're following is the right for the patient as well or not. So I tend to, if I can, measure the drug dosing and then see my dose. I start arbitrarily somewhere, start with the standard dose and see if it also depends upon how old the filter is as well, and the clearance is getting affected or not. So it's not that if you are on day 3, day 4 kind of a filter, you still don't expect the same kind of clearance in those kind of patients. So yes, in certain multi-resistant patients where you are using something, one drug to try and save the patient, drug dosing is something that you need to go on.
Sir Govind sir, what is your take?
I agree with Dr. Milind and Dr. Manoj. The best idea, best way is to get the blood levels done. But certainly in few conditions, we increase the dose of the drugs. Like the moment we start CRRT, we keep the drug as a normal. So we don't adjust as per the creatinine clearance. The moment CRRT is started, all the drugs are being given as per their body weight, rather than the renal failure status. That is one thing. Another thing, with the vancomycin, I usually gradually increase the dose to 1.5 times. As Dr. Manoj has rightly showed in his slides, the vancomycin is very easily dialysable. I remember in one of the slides he showed this when he was talking about the molecular weight and the size of the molecules. And again, amongst echinocandin, the micamycin is the different drug. So in this Cancidus and Erexis, we don't increase the dose. But if you go through the literature, there is one paper published by Honor few years back. It clearly says for micamycin, if we are using any membrane, we have to increase the dose. So whether patient is on ECMO or CRRT, you have to double the dose as a loading dose. Like as we give the loading dose, it has to be continued. A colistin, we generally don't increase the dose. Meropenem, we give a standard dose. So the rest of the medicines, they are given as a standard dose.
Akhilesh, you are mute. You are mute.
There are a few questions, if I can accept one or two types of questions. What type of filter should be used in patients with aminophylline toxicity? And can we use CRRT in severe hypothermia? These are two questions. And one more question. What is the right prescription for scuff? What is the optimum prescription and how much fluid we can remove at times with CRRT? These are three questions, please. I mean, one by one, if you can answer, right? I mean, if you can, we can start with Dr. Manoj, if you can, and then
I'll start with Dr. Goel.
Yeah.
I'm sorry, I have not used, I can't comment on the aminophylline toxicity. I don't have got any experience using CRRT into that. So what was
I think the aminotoxin with aminophylline or aminophylline toxicity, you're talking about aminophylline or aminoglycoside. I'm a bit
aminophylline.
Aminophylline.
Or theophylline, we just use standard. So we don't specifically try and treat the aminophylline toxicity with dialysis. No. We have rarely see a patient.
It is the same way you do differently?
Nah. We don't do anything differently as such. So it's just standard dialysis should be fine. I don't think we need to do anything differently. With the second one with scuff, again, it depends upon what machines are you using. So if you're using Prismaflex, you start off with the CVV HDF, and then you can actually select the dose to scuff. Scuff, all it means is that there will be no replacement given, there will be no dialysis given, and all you will do is suck more fluid off because the patient's in fluid overload. You do is negative fluid balance. You just dial in a negative fluid balance in the machine, and the machine will suck the fluid, excessive fluid off, and you're not giving any replacement. So that's the only difference with scuff. So yes, you want to do anticoagulation depends upon how long. So you usually don't use scuff for a long time. You usually use for about few hours, 6 hours, 7 hours to get the negative necessary fluid balance out, and then change it. Because again, if you continue the scuff over a night, you again cause hemo concentration, and the circuit gets clotted as well.
Okay.
Sir, one somebody has asked, like, sir, the vancomycin trough level, it is the same when you measure with CRRT, or the protocol is different?
Trough level same. We take a reference. While CRRT is going on, one can take a trough level of vancomycin and check it. As far as you are, one question was about hypothermia. So in majority of the CRRT, I am sure they are working in Australia, they must be facing more of the hypothermia than us, what we are facing here. But in majority of the CRRT, we use some sort of the fluid warmer device. And with fluid warmer device, there are certain devices where you can control the temperature. There are certain devices where you cannot control the temperature. It's a fixed temperature device is there. But if the device is controllable, then it is very easy to manage the hypothermia with CRRT.
Yeah. Do you have the cooling catheter? Do you use that endovascular cooling catheter?
No,
temperature
No,
management?
we are not having. I have never used. I have just seen it in the literature and the conferences. Never used it.
Yeah. I have used that actually. Not all the centers in Australia use that as well. And that's actually looks very elegant catheter, and machine is very good looking machine. And you put through the femoral vein, and you set the temperature. Often we have used for the targeted temperature management rather than just the hypo or hypothermia setting, even following the cardiac arrest and so. And you just set the temperature and slowly it achieves. For some reason, I don't know why, but it hasn't become that widely popular, but definitely it does good job.
I think we are almost in the end of the discussion. So just the last few points. Swapnil, Dr. Swapnil is our junior consultant. So Swapnil just like to highlight certain troubleshooting during the CRRT machine, and he will enumerate his experience, and you like to listen from everybody of us, like how we can prevent that. The last point of discussion. Swapnil, you are there?
Thank you very much, sir. Yes, sir. Yes, sir. I'm there, sir. So basically, we generally deal with repeated clotting of the filter and face a lot many times difficulty regarding adjustment of citrate and calcium levels. So in that case, we generally change the filter if it is not helping out. And we have to deal with this repeated clotting with maybe with the help of reducing the calcium citrate levels only. That's what I think Manoj sir has already elaborated it. So I don't have to anything else comment on it. Other problem we generally do face with.
What other troubles?
Yes, sir.
The other problems are air bubble entrapment is quite challenging at times.
Air leak is the
very difficult at times, and we had to change the filter. So how do we get rid of this bubble entrapment and take care of this problem? So can analyst help us with
this
the problem and the solution for this? So Manoj sir and Dr. Senap and
air locking.
Yeah.
For the air bubble?
Yeah. We have frequent problems of air bubble being trapped in the circuit, and to get rid of that air bubble, it becomes very challenging and time consuming at times, and we had to change the filter also. I know, I mean, in initiation only, I think we should, if we are not right, and probably this problem may recur. But if there are such problems, where the air is already trapped and we want to get rid of that, how do we troubleshoot this situation?
I think repriming and repriming is the only key. So you have to prime till all the air is being taken out, and you have to check the access line pressure.
Yeah, at the beginning.
Yeah, with the air bubble, you need to make sure that all the connections are
Right.
securely tight. The other thing is, if the patient has relative hypovolemia, then you have this excessive suctioning as well, which can actually entrap air bubble. So one of the things, when you have too much of a negative pressure alarm, your patient's very hypovolemic. When as I was explaining, the catheter, if your catheter has a side port and it's actually causing the vein wall to actually adduct on the holes, and there's quite a bit of a negative pressure, and you dial them on a very high blood flow rate, you often get this kind of a very high negative pressure, and you often then get these air bubbles as well. So one of the other things is making sure the patient is not very hypovolemic, giving them a fluid bolus, and see that negative pressure is alarm is also tackled up as well. Once there is air in the circuit, I don't play with the trying to remove the air. I just change the circuit. It's
Sir, we do generally change, but if it is in initial stage only, then what we can do, sir?
So I don't understand initial phase of negative air bubble. So if we all you need to make sure is, as I said, is your position of the catheter. There's no kink. All the connections are tight, there is no loose connections, and make sure the patient is not hypovolemic. So maybe give a fluid bolus and avoid that negative pressure and the suction. Maybe again starting with a low blood flow rate also helps with the negative pressure and suction.
Okay, with this, I think we are at the end of the session, and I must thank you, Manoj sir, for your in-depth analysis and involvement with the topic, and really thank you for your inputs, and hope to interact with you time again and again, and we can have workshops. And really thank you from on behalf of my entire team of Apollo Hospital. I would like to thank you. And I also thank Dr. Milind Senap sir. Thank you for coming in and pitching in and helping us with your valuable inputs. Hope to see you again and again. And Dr. Dupak Govil sir, if you're here, I mean, I would like to thank you again from your busy schedule. You participated and you helped us with your insight, and would like to see you again. Thank you very much, sir. And Dr. Swapnil, thank you very much for your involvement and your troubleshoot problems. We hopefully we will not be able to solve all the troubleshoot problems. Maybe in the subsequent sessions, probably we'll get through. But thank you for your involvement also. And I must also thank all the delegates wholeheartedly. They have participated, and I hope this program will be useful to them in their exam preparations as well, because CRRT is very difficult topics, and reading is not just enough. We need to have insights from the stalwarts, and I hope this program has enlightened every one of us.
Achilles,
Yeah.
so next Thursday we are going to have a session on cardiac output monitoring, non-invasive and invasive, both by Dr. Milind.
Yeah.
So I just again request all the delegates to join for that interesting session, and hope to see you all again. And thanks to all of you for all the panelists and
also the Australian system for the registrars and the training.
Right. So he will be going to talk on a very interesting session on the Australian pattern of the academics.
Yeah.
So it's quite interesting to listen from him.
Yeah, and if Dr. Govil is also available, can I invite Dr. Govil sir for your next topic? I mean, because I know you have done a lot of work on bioreactance and bioimpedance as a non-invasive monitoring tool for cardiac output monitoring. If it is possible, can I take this privilege to invite you for subsequent meeting on probably coming next week on
next Thursday
non-invasive cardiac output monitoring. I think Dr. Govil has left, but I will request him offline. But thank you, everyone. Thank you really very much, and hope to see you again. And good night for now. And anything else would like to, sir? I mean, Dr. Manoj Singh and Dr. Sanap, if you can brief something about CRRT to the delegates, last few words that you would like to emphasize to the students.
I think they have heard enough.
Yeah. So that's it. I think.
Sir, just one thing I really need to ask. Just a short question, sir. I will not disturb much. That's about the recirculation. That's a very much troublesome recirculation point. That's just a small elaboration, sir, please.
Yeah, again, recirculation depends upon your catheter that you use. Again, practically, it also depends upon the flow rates. I don't bother much about recirculation at all because it all depends upon your blood flow rates as well. So I rarely think about recirculation in my patients. If I need to do something, I modify my prescription. I have so many other things by which I can actually do the clearance. So yeah, catheter, because again, recirculation, unless you are thinking too much about recirculation, you need to change the catheter. I don't want to change the catheter in my patient unnecessarily. Try the other things.
Just the one quick thing, the different from this topic. One of my colleague is here. He has participated. His name is Dr. Singh, Dr. Jadu Singh. He is also involved in arranging webinars in Australia, and we have done some presentations. Different people have done the presentation. Is Jadhav, do you want to tell something? Do you want to come online?
Oh, hi, hello, hi. I'm Dr. Singh. I'm also intensive care in ICU. We do webinar every month, actually. I don't know whether you can hear me. We do every month ICU related webinar. And this next month we have critical bleeding in intensive care. Very two important, very experienced people. One is an army doctor who has been in the field during the trauma. He's going to present one, Dr. Michael Reed and Dr. David Roxby. And also we have got organ donation and end of life care by one of our Donate Life director, Dr. Stuart Moody, which will be coming next month. So we do webinar every month, and I would like, it's all aimed on intensive care trainee and DNB candidate. We have people coming from EDIC and all over European country and Southeast Asian. So it would be nice if people are interested to come in and have a listen to our webinar.
Sure.
Share the link.
Yeah.
I will. I will share some of the link.
I will give you, Jadhav. I'll give the details of Gunadhar, and you can send it to them.
We'll send it across our students and fellows, sir. Definitely.
Yes, it's very good for. It's mainly for trainees all over.
Yeah,
we have got a lot of
exchange is the way forward. Actually, we all should come together and have academic exchange.
Yeah. And it's been approved by EDIC as well. So we have got a lot of students from EDIC who comes in every month. So it will be interesting. Thank you for listening to me. Thank you.
Also, I would like to thank Misbah. She's our coordinator for this program, and she has arranged this Zoom meet very nicely. So thank you. Thanks, Misbah, from our side. And hope to see all of us soon from the next Thursday at 7 o'clock on the cardiac output mount.
So and how much time? How long is the total time? I need to talk 2 topics if I have to divide.
So you can talk on
45 minutes and then 15 to 20 minutes for discussion.
Yeah.
Okay.
Thank you, sir.
Yeah.
Thank you. Bye. Good night, sir. Good night.
All right.
Thank you, and good luck for all the students.
Good night, sir.
Thank you.